Step 2 CK final sprint. We're running a rapid drill on renal, electrolytes, acid base, and DKA. Let's go.
Section 1. Electrolytes and acid base.
Case: 65-year-old male with ESRD comes in with muscle weakness. His ECG shows tall, peaked T waves and a wide QRS complex. Potassium is 7.2. Best next step in management? Pause. Calcium infusion. The key clue here is those peaked T waves. They indicate cardiac membrane instability, meaning you need immediate stabilization. A tempting trap is giving insulin with glucose, but insulin is the correct next step only if the ECG is entirely normal, without any of those peaked T waves.
Next case. An alcoholic patient presents with muscle cramps and hyporeflexia. Potassium is 2.8, and it stays low despite 3 solid days of aggressive IV replacement. Most likely underlying mechanism? Hypomagnesemia. Refractory hypokalemia in an alcoholic implies low intracellular magnesium is failing to inhibit ROMK channels. The trap here is continued isolated potassium replacement. That's only going to work if magnesium levels are actually normal and the cause is something simple, like thiazide use.
Case: 72-year-old female with poorly controlled diabetes and mild renal insufficiency. Her potassium is 5.8, and she has a normal anion gap metabolic acidosis. Most likely diagnosis: type 4 hyperkalemic renal tubular acidosis. An elderly diabetic with a non-gap acidosis and hyperkalemia points straight to juxtaglomerular damage. The classic trap is lactic acidosis, but lactic acidosis would only be the answer if her anion gap was greater than 12 and the potassium was shifting from severe tissue hyperperfusion.
We've got 2 cases here. Case A: 22-year-old female took some unknown pills. She has tinnitus, APH of 7.42, low PCO2, low bicarb, and a high anion gap. Most likely ingestion? Salicylates. Tinnitus paired with a mixed metabolic acidosis and primary respiratory alkalosis is a dead giveaway. The trap is methanol. Methanol would only be correct if you saw an isolated high-gap acidosis with visual changes but no primary respiratory alkalosis. Case B: 68-year-old male with COPD is given heavy loop diuretics, pH 7.41, high PCO2, high bicarb. Mechanism? Mixed metabolic alkalosis and respiratory acidosis. The overdiuresis perfectly offsets his chronic respiratory acidosis. The trap here is primary metabolic acidosis. That would only fit if the bicarb was extremely low due to poor perfusion.
Section 2, AKI and urgent dialysis.
2 cases again. Case A: 80-year-old male with severe diarrhea, BUN 60, creatinine 2.0, urine sodium 10 milliequivalents per liter, bland sediment. Best next step? IV normal saline. A BUN to creatinine ratio over 20:1 with a low urine sodium means volume depletion. The trap is stopping his ACE inhibitor and observing. You'd only observe if the BUN to creatinine ratio was normal and his volume status was euvolemic. Case B: 65-year-old female, hypotensive for hours during surgery. Now her BUN is 40, creatinine 3.0, and you see muddy brown casts. Diagnosis: acute tubular necrosis. Muddy brown casts and a BUN to creatinine ratio under 20:1 after prolonged ischemia lock this in. The trap is prerenal azotemia. Prerenal would only be right if the sediment was completely bland without any casts.
Case: 45-year-old male on a PPI for 2 weeks presents with arthralgias, malaise, and a creatinine bump to 2.5. Urinalysis shows WBCs and WBC casts. Peripheral eosinophilia is entirely absent. Most likely diagnosis: acute interstitial nephritis. WBC casts following a new medication exposure like a PPI or an NSAID are diagnostic. The classic trap is thinking you absolutely need eosinophilia for the diagnosis. You don't. AIN is the answer even without it, as long as WBC casts and the drug exposure are there.
Case A: 30-year-old male found immobilized. Dark urine, dipstick is positive for blood, but microscopy shows 0 RBCs. Most likely mechanism? Rhabdomyolysis causing myoglobinuria. Positive blood on the dipstick with 0 RBCs under the microscope is classic. The trap is glomerulonephritis. GN would be correct if the microscopy showed dysmorphic RBCs or RBC casts. Let's pivot to Case B: 50-year-old female with chronic back pain. She's been taking combination OTC pain meds for years. Fatigue, UA shows mild proteinuria and WBCs, and an ultrasound shows small kidneys with irregular contours. Diagnosis: analgesic nephropathy. Chronic combination NSAID and acetaminophen use causing chronic interstitial nephritis is the mechanism here. The trap is acute interstitial nephritis. AIN would only be correct if the exposure was acute and her kidneys were normal or large on ultrasound.
Case: 55-year-old male with ESRD on hemodialysis misses 3 sessions. He presents lethargic with a pericardial friction rub. Potassium is 5.2, pH is 7.30, and there's 0 volume overload. Best next step? Urgent hemodialysis. Pericarditis in the setting of uremia is an absolute urgent indication for dialysis, regardless of his normal electrolytes. The trap is medical management with NSAIDs. NSAIDs would be correct for viral pericarditis in a patient with totally normal renal function.
Case: 28-year-old female, presents with severe resistant hypertension, recurrent headaches, and a subauricular systolic brute. Most likely diagnosis: fibromuscular dysplasia. Resistant hypertension in a young woman with a subauricular brute points directly to internal carotid and renal artery stenosis. The trap is primary hyperaldosteronism. That would be correct if she had a normal exam without brutes but came in with unexplained hypokalemia.
Section 3. Glomerular and interstitial disease.
Case: 22-year-old male presents with episodic gross hematuria just 2 days after an upper respiratory infection. Serum C3 and C4 are completely normal. Most likely diagnosis: AGIA nephropathy. Gross hematuria happening within days of a URI, combined with normal complement levels, defines this. The trap is post-streptococcal glomerulonephritis. Post-strep GN would be correct if the hematuria started weeks after a skin or throat infection and the complement levels were actually low.
Case: 25-year-old male presents with hemoptysis and dysmorphic RBCs in the urine. No history of sinusitis. Most likely diagnosis: Goodpasture disease. Pulmonary hemorrhage plus glomerulonephritis without upper airway involvement points specifically to anti-GBM antibodies. The trap is granulomatosis with polyangiitis. GPA would be correct if the patient also had chronic sinusitis, otitis media, or a saddle nose deformity.
Case A: 40-year-old male with severe, sudden flank pain radiating to the groin. UA shows gross blood, no protein, and normal-appearing RBCs. Diagnosis: nephrolithiasis. Non-glomerular bleeding causes normal-appearing RBCs without proteinuria. The trap is glomerulonephritis. GN is correct if you saw heavy proteinuria and dysmorphic RBCs. Case B: 75-year-old male with acute lower abdominal pain. He's had absent urine output for 12 hours and a palpable suprapubic mass. Post-void residual is 400 ml. Best next step: place a Foley catheter. Urinary retention with a post-void residual over 50 milliliters in men requires immediate mechanical decompression. The trap is an IV fluid bolus. Fluids would be right if the patient was hypotensive and uric and had a completely empty bladder on ultrasound.
Section 4. DKA and endocrine emergencies.
Case A: 20-year-old female with type 1 diabetes presents with vomiting, Kussmaul respirations, glucose of 450, and a pH of 7.1. Best initial step: isotonic intravenous fluids. Volume expansion is always the very first step in DKA, way before insulin or anything else. The trap is an IV insulin infusion. Insulin is the correct second step, but only after a 10 milliliter per kg isotonic fluid bolus is already running. Case B: a patient in DKA has received fluids. Labs show potassium is 3.1. Next step regarding insulin: hold the insulin infusion. Insulin drives potassium right into cells. If the starting potassium is under 3.3, insulin will cause lethal arrhythmias. The trap is starting insulin while simply adding potassium to the IV bag. You can start insulin simultaneously with potassium only if the serum potassium is between 3.3 and 5.3.
Case A: a DKA patient is on insulin and fluids. Their glucose drops from 450 down to 180, but the anion gap is still 16. Best next step: add dextrose to the IV fluids. Preventing hypoglycemia while continuing the insulin needed to close that anion gap is absolutely crucial here. The trap is stopping the insulin drip. Stopping the IV insulin is only correct after the anion gap normalizes and the patient can eat, bridging with subcutaneous insulin. Case B: to monitor the resolution of this patient's DKA, which lab test is best? Serum anion gap or direct assay of beta-hydroxybutyrate? Nitroprusside urine dipsticks do not detect beta-hydroxybutyrate, which is the primary ketone in DKA. The trap is a urine ketone dipstick. A urine dipstick is useful for initial suspicion, but never for monitoring resolution.
Case: 55-year-old male with a 25-year history of type 1 diabetes is found unconscious.
He had no preceding tremors, sweating, or palpitations. Most likely mechanism? Hypoglycemia-associated autonomic failure. Recurrent hypoglycemia blunts the epinephrine surge, completely masking those early neurogenic warning signs. The trap is diabetic neuropathy affecting vagal tone. Vagal neuropathy would cause gastroparesis or resting tachycardia, not an isolated suppression of hypoglycemic awareness. Management requires strict avoidance of hypoglycemia.
Case: 60-year-old female presents with polyuria, confusion, and nausea. Labs show hypercalcemia, metabolic alkalosis, acute kidney injury, and suppressed PTH. She takes heavy doses of over-the-counter heartburn medication. Diagnosis: milk alkali syndrome. That classic triad of hypercalcemia, metabolic alkalosis, and AKI from excessive calcium carbonate antacids gives it away. The trap is primary hyperparathyroidism. That would be correct if the PTH was elevated instead of suppressed.
Entering the final 60-second rapid-fire checklist.
ECG first for potassium. Symptoms first for sodium. Calculate pH and gap first for any acid-base question. Fluids always before insulin in DKA. Hold insulin if potassium is under 3.3. RBC casts always mean glomerular disease. BUN to creatinine ratio over 20 equals prerenal. Urinary obstruction needs immediate decompression. Pericarditis in uremia means urgent dialysis, and an infected obstruction is never outpatient reassurance.